next, it's my honor to introduce our first honor speaker, Professor Sun, who is a very well-known international surgeon in the cervical space. He was one of the founding members of CSRS AP Asia Pacific, as well as past the president of CSRS AP. He is a professor of orthopedic surgery at Peking Hospital, Peking University Third Hospital, which is one of the premier spine institutions in China. I think, with a 1.4 billion population base, I think they operate like 10,000 cases a year. They have divisions that focus on occiput to C2, and then the subaxial group, which is a C3 to 7. So, I mean, it's a completely different environment, and they see so many complex cases. And I'm just so happy and fortunate to be able to have Professor Sun to be here and share us his decades of experience in cervical spine surgery. So, please.
Thank you so much, Professor Li Tan. And I visited UCSF 2 years ago, just before the CSS attended the CSS meeting in Las Vegas. And we observed the operations, and that was very impressive. So we really had a good time in UCSF. And for the Hawaii, this is my second time to visit Hawaii. The first time was 2001, when the Medtronic Orthopaedic launched brand discs to the market, and 2 Chinese surgeons were invited to attend the training course for the CDR, this brand disc. So that was 25 years ago. So it's very pleasure to revisit Hawaii, and we are looking forward to attend our course. So thank you so much for the invitation. So today I'm going to give you so which one for the bottom? For that one. Okay. So 20 years clinical experience in our hospital. So I have nothing to disclose. So I'm from Peking University Third Hospital. So the Peking is the English name, but our city is Beijing. It's capital of China. My hospital is located where it's just about 25 kilometers away from the Capital International Airport in Beijing. So the philosophy of CDR is to prevent central degeneration of the distal segments just after ECD, after the decompression for the disc. So the first case report by Dr. Jane Goffin in 2002 in CSI meetings, and in 2003, the CDR technique come to China. So for the long-term follow-up, we always consider the overall clinical outcome and range of motion, and also the adjacent second generation disorders, and also complications. So my first case was done with Dr. John Heller, who visited China to teach the first CDR technique. So for the long-term follow-up, we look at the overall clinical outcome. So this is the paper published by our team, and this is the first 10 years follow-up paper published in English literature. And we reviewed 24 levels, and with average more than 10 years follow-up. So for the neurological, in terms of GOE score and then NDR and the VAS score for the CSM or CSR, and you look at it, it's very good. So neurological improvement is satisfactory in CDR technique. And also, this is the other paper also published in about the biggest hospital in Beijing, and compared to the myelopathy and reticulopathy, and look at that, both myelopathy and reticulopathy all had good clinical outcome. And also, this is another paper published by Chinese authors from just another city near Beijing, and it's compared to ACDF CDR in minimum 10 years follow-up. And neurological function improved as well in terms of GOA and also NDR and VAS score. But, and also about a few years later, and Protein C came to China, and also we started using that as well. And we published our paper 10 years follow-up in one center, and 7 patients were reviewed. And if you look at the clinical outcomes, all very good in terms of GOE and VAS score. Wait, does it move? Yeah, okay, thank you. So neurological improvement are satisfactory. So in different centers. So then if we check on the PubMed and the literature and see so many long-term follow-up in terms of 10 years follow-up published worldwide, and they all have a very good neurological improvement. But for the CDR, neurological improvement nothing done with what the device improved. It depends on how sort of decompression you have done. So the most important issue is the range of motion. People will always expected to have a better result. So this is one of our kids, and was 29 years old young man, and with CDR. So 15 years later, now we can see the range of motion and still maintained. This is another 10 years follow-up study. Now can see the 2-level CDR also has a better outcome. But that's just a very extreme case. But if you look at our data with a 10 years follow-up study, you can see the range of motion dropped obviously at 10 years period. So why? So what did cause it? So we found another problem with the heterotopic ossification. So when we talking about the fusion process, I always think of some patient has a non-fusion, but now facing the non-fusion technique, some patients come to the fusion spontaneously. Why? And also can see that incidence is pretty high. So the problem in our list 10 years follow-up, you can see the incidence of ossification is near 70%, and about 30% has a spontaneous fusion. And also, I think for the deep analysis, you can say that HO formation is the main cause for the reduction of the range of motion for that. So they can see it's and this is another study and published in our Chinese colleagues, and you can see compared to the myelopathy and reticulopathy, no matter what disorders we treated, it always has the same problem with very high incidence paravertebral ossification, and also has about 20% of spontaneous fusion. And this is our team result, and we can see that's all with the Protein C. So even for different prostheses, the incidence of HO is also similar, and then also have about 10% of spontaneous fusion. So if you look at the literature published worldwide and published by Michael Mayer and also Golfin, it's all 10 years follow-up for different prostheses. One is for the press C, another one is for brain disc. They all have a similar problem with just a dropped range of motion at a 10 years period. So the philosophy is for CDR is for the motion preservation. So after 10 years follow-up, the range of motion dropped. So it's really pretty disappointed. So why? What is causing it? If we look at it, all these 10 years follow-up papers, and we found the same problem is the range of motion is almost all dropped. It's come to the same problem with a different country, different surgeons. So the incidence of HO is no difference between surgeons. How about, I think everybody is familiar with Michael Mayer. He's a past president of CS Euro. And you can see the HO at 10 years of follow-up, almost 90% is pretty high. But no difference between surgeons. How about the prosthesis? So this paper published in European countries, and you can see the different prostheses, Active C and also Brandix. The HO is always similar. If you look at the range, it's here. So it's almost more than 50%, it's up to 85%. So this is our own data. The brand is 10 years follow-up from my hospital, and also 10 years follow-up from Pediatric from my team as well. You can see the HO incidence is almost pretty same. So you can see there's no difference between devices. How about the disorders? Myelopathy maybe have a higher incidence of HO. But from this study, you can see there's no difference in type of cervical spondylosis. Okay, longer follow-up. This is a 50 years follow-up study and published by Dr. Vincent Portillard. So the grade 3 and 4 HO is up to 40%, 50%. It's pretty high. But if you look at the HO group, the range of motion only about 3 degrees. But non-HO group is pretty good. So I can see the big difference. So HO formation, I think, is the main reason for the decreased range of motion after CDR. This is just we checked published 20 years radiographic follow-up published by Dr. Sasso's team. I can see the grade 4 is the spontaneous fusion. Incidence is about 10%, 11%. And so this is only 20 years follow-up. How about the 20 years follow-up data in my hospital? So let's say it's a young man and he was 45 years old with cervical spinal myelopathy. So 20 years later, and we can see that all degenerative discs are degenerated, but the devices, brand discs, are still moving. So this is another 40 years patient, a male, and you can see the spinal cord was compressed here. So 20 years later, the range of motion is still maintained. This is another one. You can see the multi-level and the most severe cords were compressed at the 5-6 level with signal change on spinal cord. And this is the 5 years later follow-up, range of motion maintained. But 20 years follow-up, now we look at the data for that. Now we can see he developed OPL at the upper levels, but for the level of CDR, still perfect, still keep moving. And this the MRI, you can see the upper and the lower and the adjacent segment at 4-5. It's a little bit this compression, but no symptoms. So this is the most updated information from hospital and 20 years follow-up. The final follow-up, the range of motion was dropped to 3.9, but an HO incidence about 90 degrees. Grade 3 and grade 4 reached about 70%. 2 patients had due to HO had a removal of disc, and 1 had an adjacent segment disorder and a reoperation at adjacent level. So, after review all these papers and our data, then we found the only one reason of reduced range of motion is HO, especially for the grade 4 here. How about adjacent segment degeneration and disease? If you look at our paper, this is 10 years for the brand disc, we have about near 50% developed adjacent degeneration on the radiograph, but no symptoms for this group of patients. There's another about 10 years follow-up study, and for the Pediatric, we did have some reoperations 3 patients had reoperation due to adjacent segment degeneration, but the problem is maybe due to the HO formation. And the spontaneous fusion is about 11% of that. So 3 of 27 cases had adjacent disorders. But if you look at the Dr. Mayer's data, 10 years follow-up for the Proteus C, then we can see they have a adjacent degeneration is about 75%. And he found that if the patient had a lower range of motion after 10 years follow-up, the higher risk of adjacent degeneration. But no AS disorders, ADS occurred. So another 10 years follow-up by another Chinese doctor and group, and we can see the similar problem with the radiographic adjacent degeneration is pretty high, but adjacent disorders, almost none. Yes, and this is 2 levels, 10 years follow-up. And you can see 16 of 209 cases had an adjacent disease, but the ratio is still pretty lower. How about this 15 years follow-up study? And we can see the upper adjacent segments and lower segment, they all have some degenerations, but in this report, there's no adjacent disorders happened. How about most updated information? 20 years follow-up. You can see 20 years follow-up published by Dr. Sosa's team. In CDA group, then the incidence of adjacent degeneration is pretty lower compared to ACDF. Nobody can have stopped the degeneration as our aging process, but the gradient is much lower in ACDF group, but no adjacent disease happened. How about in our data? 20 years follow-up, 18 cases, only 1 developed adjacent disease is pretty high, pretty low. So then let's review the philosophy of cervical CDR. Is to prevent the secondary degeneration by means of the motion preservation of operated level. So have we achieved that? So this is a paper, and I think it is published read by the Dr. Hildebrand. Anna Hildebrand is also being cited very high. So in this study, if someone had an ACDF after 10 years follow-up, they may have a chance to have 25% to develop some symptoms due to the adjacent degeneration. And this study by Japanese authors, so for the longer follow-up, if you have 70 years later, you may have a 1/3 chance to develop related symptoms due to the adjacent degeneration. So, but if compared to the radiographic adjacent degeneration and also the adjacent disorders, now we can find the incidence of those adjacent degeneration disease are pretty lower in CDR group compared to in 10 years follow-up compared to the ACDF study. So now we can say we have partially achieved that. But why we consider it partially? Because we have severe complications. One is that is the HO and the spontaneous fusion for CDR. It's a new problem when we're facing non-fusion technology. In the past, we always consider patients come from the fusion when we do the ACDF or ACCF. But now we do the CDR, they still have a problem. If you look at this meta-analysis, it's about 38 cases and 33 reported HO, 30 is severe HO, and most are taken in Asia. Why? We don't know. But maybe Asian people has a tendency to have a more bone growth. And also HO, once it happens, it keep growing. So after 10 years, then we have a problem with the target segment. So this is my case. One of my case, you can see, so the top one is lateral view, that's 3 months, then 12 months, and 24, and 60, and 120. Now you can see the HO, once they formed, it's just keep growing and growing and growing. And finally, they may cause a problem. So once the HO come to the spontaneous fusion, it will cause a G7 degeneration and disorders. And also can making a narrower foramina or even spinal canal and cause recurrent symptoms on the reticulopathy or even myelopathy. One of my patients, just I showed last week, had 2 reoperations. One is due to recurrent reticulopathy. We just removed the partial osteophyte to get symptom relieved, but 2 years later, she developed myelopathy, so we have to remove that disc and put a fusion. So that's a severe problem. So this is just one case. You can see the first time, and we just did some decompression on your foramina. But 2 years later, and we have to remove the whole disc. So if you look at these literatures, the reason for the reoperation after CDR at the index level is due to the HO. At the adjacent level is the degenerate disorder. It's also due to the lost range of motion due to the HO formation. So this is my case of that. There's another paper published by Dr. Goffin. He was the first reporter of a brain disc. At this 10 years follow-up study, you can see the patient also have a very severe osteophyte formation around the prosthesis. So in this case study, 7 patients had reoperation, 2 in index level and 5 in adjacent level. It's all due to the HO formation. At this 15 years follow-up, 10% patients require surgery for cervical stenosis due to HO at the prosthetic level. So, and if you look at this data, sometimes it's quite disappointing. Oh, we don't want to reoperate once we put a cervical device, CDR, for my patient. But if you look at this, the CDR has been proven worldwide since 2000. And in China, between 2008 and 10, it achieved the peak. Almost every spine surgeon want to do that because it's the most advantageous technique. They want to hold this. But soon afterwards, some prosthesis sales dropped and resold to the other company, or even withdraw from market. With all these prostheses, they all disappeared in Chinese market. We don't know why. And also in other part of the world. But in US, I heard during the past 2 or 3 years, CDR is increased dramatically, but in China still maintained. So this graph, you can see in our hospital, we have 2 peaks. One is due to this 2008. It's about near 90 cases per year we performed. Then 2012, we dropped. We are almost stopping doing that because we found so many problems. So we have to reconsider what's happened, what's wrong with us. So after we realized the problem with the patient selection and also the surgical procedures, then we set up much more restricted inclusion criteria. Then afterwards, you can see that CDR performed just about 50 cases nearly with pretty steady. So by reducing the HO formation, we reduce the rate of operation rate. So one of the issues is the selection of patient and also the prosthesis. So what's the correlation between the heterotoxication and the patient selection? This is from my paper by my team. Actually, 5 years follow-up of brain disc, the HO happened in almost 50%. All these cases has the problems decreased range of motion before the operation and the calcification of ALL and obvious degeneration on loose skull joints and also ossified formation, and even some OPL. We don't realize OPL will cause some problems. So, and this is another different processes, also 5 years follow-up. And look at all these preoperative radiograph, we found so similar problems with decreased range of motion before operation, calcification of AAL, and obvious degeneration of Luschka joints, and also big also formation and OPL. So one similar problem. So after that, we studied the further investigation for that, and we found the risk associated with hospitalization is the loss of disc height will lead to the high incidence of HO, and also by this the written by Professor Fifi Zhou, he was sitting here, we do the presentation tomorrow, and he had progressive bone formation after CDR with a minimum 5 years follow-up, and reviewed all the cases. We found that before the surgery, if patient has more severe degeneration with a higher incidence of HO. We use this Kellen grade for evaluate severity of preoperative degeneration. And we found this problem. More severe preoperative degeneration and a high rate of postoperative HO formation. So the factors for development HO formation and progression is degeneration of a target segment. And we found that why they have this. For the FDA IDE trial and some European CDR trials and all this paper, the loss of this height, if less than 50% is indicated, is a good inclusion criteria for CDR. But in Chinese surgeon, we found that if they lost more than 20%, less than 20%, with a much better result after the CDR procedures. And also the range of motion in all the FDA trials and European trials, if the range of motion more than 2 degrees will be included. All these published in these papers, but Chinese surgeon we found that if the range of motion of target less than 66 degrees, we have a higher incidence of HO formation. So that means more than 60 degrees will be better. And also formation anterior posterior margin of the vertebral body. There's no quantitative, only qualitative and no quantitative analysis. But it's pretty difficult. But in our study, and also Chinese Taiwanese authors, we found that obvious formation use Cannon-Lawrence grade will be much more accurate to have a better selection of the patient. And also, we sometimes ignore the Luschka joints degeneration, but we found in cervical disc, Luschka joints is so important to maintain the range of motion for that. And in this study, if joint have a hypertrophy, the incidence, the HO formation will be much shorter. That means if less degeneration, will be less incidence of HO formation. So then we developed an evaluation grading for the ankle vertebral joints, the class 1 and 3. The class 3 will be fully fused, and the class 1 means no degeneration. So according to that, we found that if the patient have a more worse Luschka joint degeneration with much more worse severe HO formation for that. And how about the facets? Cervical disc is very most complicated unit, motion unit for the spine. So in this study, and the Korean surgeons and found that the grading is normal, is grade 5, is fused. And the Chinese surgeon found is more degeneration for the facets, is a higher incidence of HO formation. So after that, I think after all reviews, data is pretty good, much more data, and found that most of the important issue for patient selection is soft compression only. So after that, now we set up this very strict criteria for the patient selection in our hospital. Then the HO formation we dropped. And so what's the difference in types of devices? We look at the data, it's not too much data, but you can find the difference. The Mobi-C and the Proteus-C is quite different. And also the HO in relate to the types of prostheses. There's 3 different prostheses here: Buccal C, ProC, and PCM. And Buccal C is called what more or less anatomic end plate. So the first generation of CDR, you can see, is quite complicated. It's the end plate for devices is so different. It's varied. So for the procedures, we have to do much more milling and milling to let vertebral end plate to fit these metal surfaces. But for just like this. But for second generation, now we can see that it's called anatomic shape and end plate. So for the surgical procedures, there's no much dealing with the bone cutting. So preserve more bones, less recover for the bone surfaces. So maybe less progression of HO formation. So this is 1 or 2 levels data for 5 years for the Buccal C. The severe HO formation is pretty high, lower. It's only 12%. How about our data? And we said since 2014, during the past 10 years, we almost use a very restricted indication for this ProDisc Vivo, and look at our data. And this is ProDisc Vivo, and that one published many years ago with ProDisc C. So the core of that is similar, but the difference is just the surface of the end plate. So let's start the result. You can see the severe HO is big difference of that. For ProDisc Vivo and also restricted indications is only 14%. But that one is about 50. So this 10 years follow-up published by Dr. Pollard with the Buccal C, see the almost preserved motion with 7.4 degrees. That's very good. And also surgical steel is also important. About the basic principle of this, and also the PLL, and also bone wax seal the bone removing cutting surfaces, and raising it. And also the most important thing, I think, is the use of drugs of non-steroids. And also from the literature, there's so much literature how to use the non-steroid, but all these literatures give some ideas about reduce the occurrence of HO by means of the non-steroids. It can help. So this is and also the published by Dr. Pollard. The recurrence of HO operation is influenced by selection of the patient, type of implant, and the surgical technique is so important. And also, it's also been readdressed by Dr. Sasso in this 20 years follow-up study. Anti-inflammatory drugs and patient selection and surgical techniques are all important. So after review that, after 20 years experience, and Chinese surgeons has come to the similar agreement, so we made expert concerns about the clinical application of that to standardize the surgical indication, patient selection, and surgical procedures and perioperative management. I hope after that, in another 10 or 20 years period, then we can have a better outcome, better result, can help this non-fusion technology progression. So, take-home message. Cervical artificial disc is safe and effective operating procedures. For the 1 or 2 segment disc disorder is very effective, and clinically effective can be maintained more than 10 years. The incidence of adjacent segment disease is pretty low, but if we can reduce the incidence of HO, that can further improve the clinical efficacy. Thank you very much.
All right, Professor Sun, thanks for a great talk. I'll ask the first question while others getting ready. I think you really mentioned a key point is that for arthroplasty to work well, you really need to not only look at the disc space, but also the onset joint. I get referred a lot of revision cases where patients after surgery, they have persistent or even worsening symptoms because they have a severe onset hypertrophy and they still have radiculopathy. So How do you deal with that? Do you do onsenectomy with arthroplasty, or if someone needs onsenectomy, it's automatically a ACDF in your practice?
Yeah, if they have a very severe degenerative on the onsenectomy, we just perform the ACDF. Yeah, we just want to try to hold this non-fusion technology going healthily, rather than so many other factors influence the final result. That will make people disappointing.
Thanks for the beautiful lecture. Using the anti-inflammatory is very good to prevent heterotopic ossification. Does it interfere with the integration of the implant into the bone?
Yeah.
So how do you balance getting the implant to integrate to the end plates versus the HO formation?
I think in our cases and also in Chinese surgeons' experience, the immigration of the implant is pretty low. We didn't find a similar problem, but non-steroid only give 1 month, but not too long. 1 month, I think is yes.
Wonderful talk. It's good to have the long-term follow-up, because we do see the patients that come back to us and their discs doesn't seem to move as much. What I don't truly understand is we use the non-steroidals early. How does that prevent HO 10 years down the line? It doesn't totally.
I don't have idea about that, but we found this. Some patient they take non-steroid and have a reduced pretty lower HO grading. Some patients they just don't take that, then they have pretty high. So there's not much studies on this issue, but just for the 10 longer follow-up 2 papers, one is Dr. Zasso and 20 years, and one is Dr. Partilar 15 years. They all mentioned the non-steroid can help reduce that.
And the follow-up to that is, when you have HO, like in some disc prostheses, like the ProDisc C, the HO occurs typically where the keel is cut, and there's some bone marrow that comes out. So you have a little bridge of bone across it.
Yes.
And it's not as much the HO occurring in the back along the canal as much, maybe a little bit on the uncinate, maybe. Do you ever think about just going in and removing the HO from the front and restoring some of the motion? If they have only anterior-based heterotopic bone?
I never do that. But our colleague in Shanghai, he did this. No, in Beijing, he did the same one. He just removed that and re-put it again. Just single one case. It doesn't mean anything, I think. Yeah.
Okay. Thank you.
Thank you. Thank you very much.
Yeah. So thanks, Dr. Sun. I think I probably falsely thought that my heterotopic ossification rates were low, but I just haven't followed them long enough. So it's really nice to have long-term follow-up. But my question is, you showed a pretty dramatic difference between the ProDisc C and the in vivo. Do you think that's just the actual biomechanics of the implant, or do you think it's the selection criteria that you changed over your original 10-year experience?
I think the profile of the end plate is very important. So and I thought that's why the ProDisc C has withdrawn from the market. Yeah. Okay. Thank you very much.
All right. So I think we have